Okay, so good afternoon, everyone. My name is Bruno. Today I'm going to present the evidence-based medicine session. So the structure for this lecture is a bit different from the previous ones. I'm gonna present an article related to myeloma, but the focus is not myeloma itself. It's just to discuss one topic related to EBM. So throughout the lecture, I'm gonna ask some questions, but for some of the questions, there are no right or wrong answers. So feel free to discuss and put your thoughts on the table. So this is the article I chose. Is a paper comparing low dose versus high dose thalidomide for advanced multiple myeloma. So just a brief introduction about multiple myeloma. Is a disease characterized by abnormal plasma cell proliferation, increased production of monoclonal protein, and organ damage. It's the second most common hematologic malignancy after lymphoma. There are some specific diagnostic criteria to determine that if the person has myeloma or not. First, I have to have bone marrow plasma cells greater or equal than 10%, or a biopsy-proven extramedullary plasmacytoma. And then one of more biomarkers of malignancy, or one of the CRAB criteria that all of you guys already know. And then generally, I categorize the disease in two different groups. So I have the newly diagnosed patients and the relapsed refractory patients. The relapsed refractory ones are the ones that are non-responsive or progressive while on therapy or within 60 days of the last treatment. So generally, the way that myeloma treatment is done is that for newly diagnosed patients, I do high-dose chemotherapy and then autologous stem cell transplant to permit the patient's bone marrow to recover from that injury provenient of the chemotherapy. Then for the relapsed refractory patients, I try other stuff, generally combinations of agents with different mechanisms of action. So this is just a timeline showing how myeloma research is on fire now. So we had like 20 agents approved in the last few years. A lot of options, a lot of lines of treatment for relapsed refractory patients were developed over the years. And then the specific agent we're discussing, called thalidomide, it's an immunomodulatory drug. It was actually the first in class for the immunomodulatory drugs. It has pleiotropic effects such as anti-proliferative effects, anti-angiogenic effects, co-stimulates T and NK cells. And all of this together contributes to generate an anti-myeloma effect for the patient. So basically, it binds to a receptor that after that binding of the thalidomide, it changes its shape, starts to bind to proteins, and it starts to simulate the degradation of those proteins. And those proteins are mostly proteins related to those processes, like angiogenesis, proliferation of the B cells. So thalidomide, by doing this, permits all of those anti-myeloma effects. So generally, I can use it as a single agent or in combination with steroids. And the adverse events related to it are constipation, somnolence, peripheral neuropathy, and venous thromboembolism. So again, this was the article I chose, low dose versus high dose thalidomide for advanced multiple myeloma, prospective trial from the intergroup Francophone du myelome. And then the study design, it was a multi-centric, open-label, randomized controlled trial, phase 3 trial. And anyone could tell me what all of those words mean for a trial?
Bruno, you may have to go to the next slide.
Yeah, I think we're still seeing the introduction.
The timing. There you go.
Oh, sorry, let me. I'm sorry, is still the methods one? Is
Yes,
that the
now
methods
We have the open label randomized control trial slide.
Oh,
So as
okay.
Bruno mentioned earlier, no answer is a wrong answer, so y'all can chat or unmute yourself. So what does that mean?
It means that the study was made in different centers. It could be in different places around the world as well. Open label is a trial that doesn't have any blinding. Randomized meaning that they did a randomization process to decrease selection bias. Controlled trial, meaning that they use like placebo or versus the medication maybe. And the phase 3 is a trial that is to assess like maybe the effectiveness of the drug. Yeah.
So that's perfect, Lenny. So exactly. So it was done in 49 centers in France and Belgium. Actually, like you said, open label. So everyone was unblinded. Both the clinicians and the patients knew the treatment that was being given. Patients were assigned to each group by chance. Control, like you said, I have a control group, a comparison group. And then phase 3 trial, because it was a trial to confirm efficacy of a drug. And because of that, I included a higher number of participants. For a phase 3, generally between 300 and 3,000. And then, so the interventions were, in one arm of the group, arm A, patients received thalidomide 100 milligrams per day. And then on the other arm, arm B, patients received thalidomide, the same drug, 400 milligrams per day. So what do you think that would be the main goal of the study? Considering we already knew at that time that thalidomide had anti-myeloma activity, that already had some degree of efficacy against the disease. So why would we create a new study dividing patients in two groups, being assigned to receive different doses?
Would it maybe rates of relapse or like after treatments completed, possibly?
That's a good point, and but there are also other things that anyone has any other thoughts that we could
and maybe to look into dose-dependent effects of the drugs.
Perfect. Anything else?
Is there a reduced side effect profile with like a lower dose versus the higher dose?
Perfect. Exactly. That was exactly the goal of the study, to compare the efficacy and the safety of two different doses, to prove that one dose was either superior or non-inferior to the other one. As like I said, although the anti-myeloma activity of thalidomide had already been proven, the ideal dose was not determined yet, and thalidomide was associated with all of those side effects. So the main thing that researchers were asking them, okay, if I give those patients, those myeloma patients, a lower dose, would I still get the same efficacy and get them to have less side effects? So that was the main thing they tried to find out with this trial. And considering that, in considering what you guys may have already seen about other trials on cancer agents, what would you say are the primary and the secondary endpoints of the study?
He's saying basically when you looked at hematology oncology studies, what do they normally look for?
So Omar wrote in the chat, remission is a primary.
Okay.
So you guys see a cancer remission. Jonathan is saying mortality.
I think it's response to treatment, to the dose, to a specific dose, maybe.
Raj is saying more specifically 5-year survival. That's mortality.
Perfect. Those were all great ideas, guys. And then for this study, let me. So for this study, before the primary and secondary endpoints, those were the inclusion and exclusion criteria. So for inclusion, patients age greater or equal than 18 must have had a minimum two lines of prior therapy or 1 line of therapy, including, like I said, high-dose chemotherapy and autologous stem cell transplant. And the exclusion criteria, patients obviously could not be pregnant, as thalidomide has very well-known leads to congenital abnormalities, could not have any other agent being associated to the thalidomide, and could not have a history of DVT, as it was one of the side effects associated with thalidomide. So then, like you guys said, those were all great ideas. So the primary endpoint for this trial specifically was a per protocol comparison of overall survival at 1 year. And the secondary endpoints were an intention to treat comparison of overall survival at 1 year, overall response rate, time to first response, overall survival, progression-free survival, and rates of adverse events. And then, so from what you guys may have already seen in previous studies, may have already read, what do you think is the difference between a per protocol analysis and an intention to treat analysis? What would be the definitions for both of those approaches?
When you do an intention to treat analysis, you don't exclude any patient. Like, for example, if a patient died during the study or drop out of the study, you do like certain things to include those patients in the study as well. So you include everybody, no matter if they drop off out of the study, or in this case, die.
And what do you think would be a benefit of doing that?
That's a good question. I don't know right now.
It's more
Anyone has any thoughts?
Yeah, it's more realistic to like real life examples and patients being treated, rather than like one person is not going to be stuck on one protocol, because things change.
Perfect. And then for the per protocol analysis, what is a per protocol analysis?
Oh,
Yes.
another thing, sorry. Another thing is that considering this is a disease that is very like aggressive, you don't have like that much patients to include in the study. So it was good that they did like a multi-center trial, because it's a little bit difficult sometimes to get patients with this kind of diseases. So the intention to treat comparison will allow to have more information at the end of the study of the patients.
So I was gonna comment on 2 different points. So one is what Omar wrote too regarding preserving randomization, possibly is one point that Omar had. And then kind of elaborating a little bit on what Lenise said in the beginning. A better, like a way to say is that you include patients regardless if they receive the intervention or the medication that you're looking at. That's like just adding that little layer, not just including everybody, but including everybody regardless if they receive the intervention or the medication that you're looking at, to see if there's an effect or not. And then elaborating further on what Tyler and Lenise were kind of saying, that if you, especially for a lot of this, you're going to see like more in hemonc world, but rheumatology, like places where the incidence of whatever disease or that you're looking for is very small. The other thing that you do by doing, including everybody, regardless if they receive the intervention or the medication, is what do you preserve? Like, what are the things that you have to look at before you even start enrolling? What is it that you have to calculate? You have to calculate what in order to say that you have another thing. It's usually in your methods and statistical analysis. So you have to calculate the sample size, right? You have to calculate how many you need to enroll or screen so that you can say that you have enough power to say that you made a difference, that there's a difference. So one of the things that this also allows is that it tries to maintain the power that your study had in the beginning by keeping those numbers there. And that's just like another point just want to make, but go ahead, Bruno.
Those are great points. And then for the per protocol analysis,
Just
what
to
would
clarify, Bruno, as well, like you're still in the method slide. I don't know if you wanted to like change that slide or if you intentionally like stay there.
Oh, me.
It's okay. Yeah, I missed that too. There you go.
Okay.
So the per protocol analysis is to include, as the name implies, the patients that only those patients who completed the treatment that were like originally allocated for that treatment.
And what would you think is the benefit of doing that?
That's another good question. I don't have a specific answer right now.
Any thoughts? Anyone?
Yeah, I mean, yeah, I guess the question is, what would be the benefit of actually measuring the outcome when someone takes the treatment exactly as specified and actually follows through? Like, what would the difference in effects be when you analyze a sample like that versus, you know, someone that might have been assigned to the sample, didn't have a good outcome, but wasn't really taking the medication?
Then I think we can attribute the results to the intervention.
Can you repeat that, Salvador, just because it was very low?
I'm sorry. So I think per protocol analysis allows you to better attribute the results to the actual intervention and not to the other factors, as we discussed before with intention to treat analysis.
Yeah, exactly. I think that's a good point. So it's very great for, you know, your phase 1, phase 2 trials when you actually want to, you know, analyze that either, you know, toxicity or that therapeutic effect of the biologic agent that you're analyzing. It's very good for that. But then again, like we were talking about the intention to treat, gives you a little bit more real life example, you know, as to why, you know, maybe they weren't following through because it was, you know, because of the toxicity of the medication or because it's hard to administer the medication. And those are all like, you know, real world examples and a little bit more akin to what you'll see in real life. So it's definitely benefits and cons to both things, but Bruno is gonna talk about them a little bit more in depth further on.
Any questions from anyone regarding that? Because I know everyone's different. Everybody understood. You can just put like a thumbs up or shake your head or no.
Yeah.
Okay, for those on video.
Yeah.
For those not on video, could you at least put like your thumbs up emoji that you're like, good and that you understood everything?
Yeah, and I would say that
get one thumbs up, it'll be good. But no, we're not.
Yeah.
Okay, go ahead, Bruno. We're trying.
Okay, and then so for intention to treat analysis, as we were discussing, all participants who are randomized and included in the statistical analysis, all patients who are randomized are actually included in the statistical analysis, and regardless of what treatment they have received. So it measures the effect of assigning a patient to a treatment, even if that patient get no intervention at all. So that will include the differences in patient adherence, and that would correspond a lot to a real life scenario. Considering that, we would be able to maintain that balance, those beneficial effects of doing a randomization, of assigning patients randomly to different groups in order to guarantee that they have similar characteristics. And with that, that would be the most commonly used approach for the primary analysis of randomized controlled trials. However, even though it is the most commonly used and even though it has all those benefits, can someone think of a possible drawback of doing an intention to treat analysis?
It reduces the statistical power of the study.
Just based on, Tyler's description of intention to treat, I'd imagine folks who don't complete the trial, it would skew kind of the data a little bit to measure the effectiveness of the medication versus placebo, because you're still including them.
Yeah, so I would turn a little bit of what Neha said about the statistical part, but more with what Raj was saying, is like you decrease the validity of the results that you're getting. And it's like another way of just kind of saying that because you are keeping everybody, regardless if they receive the intervention or the medication, you may not get like the true effect of what the medication is actually doing, or intervention, which is what the protocol would allow you to get, because you're only really including the people who received it. So it's like another way. So I wouldn't necessarily say it decreases the statistical power. I would say more that it decreases the validity of the results that you're getting. You really have to make sure that what you're seeing is an actual effect of the medication or intervention of the study, of what you're looking at.
Exactly. So with the intention to treat analysis, sometimes I'm not able to evaluate the best possible scenario, the exact treatment effects, the exact treatment benefits, because there will always be the adherence issue. So, and also, for example, the adherence to a treatment in the clinical trial may be different to the adherence of a treatment after the drug is approved, after the drug is marketed. And if we stop to think about it, wouldn't like each and every one of us be more compliant and use a drug on a consistent basis according to the protocol if we knew that was effective? And that is also a possible drawback of an intention to treat analysis. It fails to recognize that the degree of adherence outside the trial may change drastically after patients learn of the trial's findings. So I have a personal example of intention to treat analysis. So back in Brazil, we did a trial trying to confirm the efficacy of a novel treatment for burns. And for that, because we were trying to study this novel treatment that was not approved, not used before, we did the intention to treat analysis. And the importance of the ITT in this case can be exemplified by the fact that the tilapia skin took like 1 day to adhere to the wound bed. And so we recommended patients, okay, please do not move the lamb or the affected area a lot during the first day, because that would be the time that the tilapia skin would be adhering to the wound. But obviously there were some patients that would not follow those recommendations, that the tilapia skin would move from the wound area, and that would decrease the efficacy of the intervention, as there would be less contact of the tilapia skin with the wound bed. So if we ended up excluding all of those patients from our final analysis, that would actually create a lot of bias, a lot of confounding factors, because we would be only including in our analysis patients that follow the protocol perfectly. So it would like, okay, we're evaluating this new drug, and then on the analysis, we're only including patients that did everything right. So I would definitely get better results for that drug, but they wouldn't apply to a real life scenario in which some patients would follow your recommendations as a doctor, other patients would not follow your recommendations as a doctor. And then for as treated and per protocol analysis, so we measure the effects of an intervention under ideal or experimental conditions. So it checks the efficacy on the best case scenario. It answers the question, what is the effect of receiving a drug in a group of patients in the best possible scenario that all patients adhere to treatment, that all patients follow the protocol. So for the as-treated analysis, I consider the treatment actually received by the participant with no regard to adherence to their randomization assignment. And for the per protocol, we only analyze data for patients who actually follow all the rules, who follow all the protocol, excluding their data if they did anything wrong or if they were non-adherent. And what would be the problem? What would be the drawback of using such an approach of excluding those patients from more final analysis? We have already talked about it a lot, but anyone has any extra thoughts about it?
When you exclude the patients from the analysis, you are missing some important information that can be provided by the study, you know, important data.
Exactly. As appealing as it may seem to use as treated or per protocol analysis, we would create selection bias and confounding in the treatment effect, because we would be excluding from our final analysis patients that they did not adhere, but okay, maybe those patients did not adhere for a specific reason, for a specific baseline characteristic. So in the end of it all, the groups of patients that I would analyze in each arm would be patients with different characteristics. Because, okay, some characteristics may contribute for them to follow the protocol, to adhere to treatment, but other characteristics may lead them to not follow the protocol, not adhere to treatment. And however, there are some situations in which per protocol and as treated analysis may be useful. Can someone give me a real life example in which that would be very important to get the information of the best case scenario efficacy?
For example, patients who received a surgical intervention, in that case, you need all the patients that follow the protocol.
Yes, exactly. And then another important example is, for example, for contraceptive methods. So we need to know the best case scenario. We need to know the best possible efficacy of contraceptive methods in order to give that information for patients sometimes, in order for them to do their decision for which contraceptive method they want. And the only way of getting that best possible efficacy would be through per protocol or as treated analysis.
I think in general, I think the best analysis are when they include both, but I think the big thing, especially like I'm thinking of some of the other things like health disparities and marginalized populations and how per protocol versus intention to treat really miss a lot of patients, depending on who's getting enrolled and those types of things. But the other thing is just cost of the medication. So you have to make sure that whatever you're doing and saying that it's effective, you also need to make sure that it's effective so that you can say that the cost that you want the insurance or what, you know, whatever government society to pay for it. Like you can say that it's effective because you have adherence measures, be it blood levels or hair, hair drug levels, to make sure that you're saying these individuals were adherent. And we can say that as long as people are adherent, you know, that this medication is reasonable to cover. And one example very easily was back in 2011 when Truvada was approved to be given for for PrEP. And that study came out in December of 2011, and the FDA in the United States gave guidance to start it in February of 2012. So within 2 months, just because they were able to say that if individuals took this medication, you were going to prevent, you know, infections getting acquired from individuals who are considered to be very high risk. So I think the cost needs to be put in there as well for the medication or the intervention that you're trying to say is effective. So that would be my only other take for the situation.
Thank you so much, Dr. Osorio. And that was actually something that I did not realize that I had not included in the main applications, but it's a very good example of a situation in which that would be important and that would be applicable. And other three main situations in which the protocol or S-treated analysis would be important would be to check in the best possible response, as we were discussing as well. Interpreting non-inferiority trials, and then to analyze the adverse effects of treatments. So the last two options would both apply to, or the study we're discussing on myeloma. So we want to prove the non-inferiority of one dose compared to the other, and we want to analyze the exact rate of adverse effects of a treatment. And both things are like Dr. Osorio was saying, it is always better when we have both, but in order to address those things, we would need protocol analysis for sure. And then I had a video over here. I don't know if the audio will work, but let's try. Are you guys hearing it well?
Maybe you may have to, when you shared it, did you click the bottom with the audio? Like reshare it? And then make sure that the bottom says audio.
Okay.
There.
So I go out of the presentation and then read.
Oh, no, just go to your Zoom at the bottom, the share screen. Click it, and then make sure that you're clicking audio at the bottom.
Okay. Oh, share sound.
There you go. Yeah, then it should work. Yeah.
Working. Okay.
Hey, welcome to Sketchy EBM. I'm your host, Anthony Crocco, and today we're talking about intention to treat. So a few years ago, Halloween as it turned out, I bought a whole bunch of candy thinking that I was going to stay home and give it all away. Turns out I made other plans, didn't give out the candy. I certainly had the intention to treat, but it just didn't work out that way. We're not talking about that today. What we are going to talk about is a concept that sometimes comes up when you read a randomized controlled trial. In very basic terms, a randomized controlled trial has a randomization process that divides the participants into two groups. On one hand, you've got the experimental or intervention group. On the other hand, you've got the control group. Now, of course, we do hope that members of the experimental group will actually conform to whatever it is that they're supposed to be getting as part of being randomized to that group, and the same goes for the control group. Sadly, it doesn't always work out this way. Sometimes participants may deviate from the protocol of the experiment. This can happen for random reasons, for instance, just getting the wrong intervention, but it can also happen for very specific reasons. For instance, members of one group may get side effects. These participants may decide to stop being compliant with the protocol. This leaves a potential for bias within the results. So now the researcher is stuck. They are asking themselves, what should I do with the data that results from these non-compliant participants? I think the best way to explain this is through a couple of examples. And for our fictional studies, there's two truths. The first is that there's no difference between the experimental group and the control group. The second is that 75% of everybody gets a good outcome. So here we have our control group and our experimental group. And both groups are going to have 4 participants. 3 of the 4 participants in the control group have a good outcome, 75%, as do 3 of the 4 participants in the experimental group. Now imagine for a second that this fourth participant in the experimental group, the one with the bad outcome, just so happens to be non-compliant with the experimental intervention. What should we do with their data? Well, we could throw it out and say, you know what, this data is corrupted. We could say, well, you know what, we'll move you over to the control group because effectively, you know, you weren't really treated like the experimental group, or we could just leave them in the group that they were originally assigned. As it turns out, each of these options has its own EBM name. The first option, called per protocol, is where we only examine the data from participants who were compliant with the methodology. The second option, called as treated, examines participants' data in the group that they actually conform to, regardless of which group they were randomized to. The third and last option is called intention to treat. With intention to treat, we actually keep all of the participants' data in the group that they were originally assigned to by the randomization process. Well, now let's see what happens to our results based on these three different approaches. Per protocol, removing the participants' data entirely means that we're still left with 75%, or 3 out of 4, with good outcome in the control group. The experimental group now only has 3 participants, and all 3 of these participants have a good outcome, giving us 100%. Our second option is to use the as-treated protocol. If we do this, we move the participant to the control group. The control group now has 5 participants in it, 3 of which having a good outcome, giving us 60%. Our experimental group is again left with 3 participants, all of which having good outcome, giving us again 100%. The final way that we can look at this data is to use intention to treat analysis. We're going to keep all participants in the group to which they were originally randomized, no matter what they did. When we do this, both groups are left with 3 out of 4 participants having a good outcome, giving us 75% for both the control and experimental groups. Let's go through this exercise again, but this time, let's pretend that it's one of the participants in the experimental group that had a good outcome. Again, we can either per protocol remove them from the study, or alternatively as treated, move them to the control group, or use intention to treat analysis and just keep them where they were randomized to. Well, let's see what happens to our results now. Per protocol, we're still left with 3 out of 4 participants in the control group having good outcome, or 75%. We now only have 2 out of 3 participants in the experimental group having good outcome, or 67%. If we use the as-treated protocol, we move the participant from the experimental group to the control group. The control group now has 4 out of 5 participants having a good outcome, giving us 80%. The experimental group is now left with 2 out of 3 participants having a good outcome, or 67%. Finally, using intention to treat analysis, we keep everyone where they were originally randomized to, and we get 3 out of 4 participants in each group having a good outcome, giving us 75% in each group. Now I want you to bear in mind that these are both very simple examples. There are a number of different ways that non-compliance or non-adherence to protocol can interfere with data. And as it turns out, the best way to manage the potential bias that occurs from non-compliance or non-adherence is to use intention to treat analysis. Most randomized controlled trials have something called a consort diagram. The consort diagram actually depicts what happens to the data from each of the patients that were included in the study. I think it's a good idea to always make sure that randomized controlled trials have a consort diagram. And look for intention to treat analysis, because it really is the best way to minimize the effects of bias that occurs from participants in a study that don't adhere to protocol.
Oh, okay. So getting back to our study, so there was the diagram for patient disposition. So can someone tell me which group is the red line and which analysis corresponds to the red line, which analysis corresponds to the yellow line, which analysis corresponds to the blue line? So at first we have all 400 patients that were randomized, and then depending on the situation, we started to take patients for some reasons. So for example, from the first group, we took 3 patients because they died and didn't receive any treatment, 2 patients because they died, received no treatment. And then we started to take patients with deviations from the protocol. So which type of analysis do you think would be done if we consider the first group as a whole?
Intention to treat.
Perfect. And then for this second group, the yellow group, that we took patients that didn't receive any treatment, because they died.
I think it would be as treated.
Yes, exactly. Because then I would be analyzing the patients considering the treatments they actually received. So I would only include in the analysis people who actually received the thalidomide. And then for the last one would be the per protocol analysis, because then I'm removing patients that deviated from the protocol and including in the final analysis only patients that adhere to the protocol. Okay, and then finally for the methods, those were the statistical tests used. Not that much important for the discussion for today. But then the only thing I would like to point out is that they did those crazy statistical calculations and figure out that the upper limit for non-inferiority would be upper limit of 12.75% between the difference of the overall survival of the two treatments. So when they calculated a confidence interval for the treatment in overall survival, if the highest value that was obtained was at least 12.75%, then there was a superiority. If lower than that, there was non-inferiority, and that was the criteria used. Then that's the table with patient characteristics. What is the most important thing that we looked at the table that we, what is the importance of having a patient like a table like this? So as time is getting shorter, so the thing I would check would be the p-values to make sure that there are no difference in the baseline characteristics for each of the groups. So I see that all values are greater than 0.05. So that means that the groups are similar in the baseline characteristics. And then for our results regarding the 1 year overall survival, this is what we obtained. So for the per protocol population, the upper limit of the one-sided 95% confidence interval was estimated at 15.67%. And as we discussed, the limit of non-inferiority was 12.75. So for the per protocol population, actually, the 400 group was superior to the 100 group. But then for the ITT population, when they determined the 1 year overall survival rates and did similar calculations, the upper limit of the one-sided 95% confidence interval was estimated at 11.49%. That was lower than the limit of non-inferiority. So for per protocol analysis, thalidomide for 100 was considered to be more efficacious than 100. But then for the ITT analysis, there was no superiority. And then, okay, so, and this is what we discussed. So non-inferiority of thalidomide saying 100 could not be established for the for the per protocol group, but the non-inferiority of thalidomide 100 could be established for the intention to treat group. Overall survival, progression-free survival was not different for the 100 and 400 group as well. As we can see, the p-log rank was greater than 0.05, both situations. So in the ITT analysis, overall survival, progression-free survival was similar between the two groups. And then for the overall response rate, the 400 group was actually shown to be more effective than the 100 group. So the overall response rate obtained with the 400 group was significantly higher than the overall response rate obtained for the 100 group with a p less than 0.001. And that was the rate of adverse events. So what can we figure out from that table?
Well, you have the statistical significance on the right side, right? Next to the side effects. So anyone care to guess what's significant, important here?
You can see which effect is going to be have the greatest impact on patients.
And Tyler,
Exactly. So
Tyler, sorry, go ahead.
Yeah, I
Tyler.
was just gonna say the only one that seems significant is the higher dose of the thalidomide caused more somnolence with a significant value versus the lower dose group.
So for the higher dose of thalidomide, we had increased somnolence, and as Tyler said, and then we also got increased constipation, and most significantly, most clinically significant was that the rates of peripheral neuropathy were higher for the 400 group, and that is actually very clinically significant because it's a very common reason in clinical practice to decrease or discontinue the dose of thalidomide. So then from all the results we got, what do you guys think? Which dose would you use for your multiple myeloma patient?
Yeah, and I think this is a particularly interesting article because of that, because you have like the different effects when you analyze it as per protocol and intention to treat. So I think a good way to think of it, or like the first thing you need to think is, why were these results different? Why do you think you had different results in the per protocol populations versus the intention to treat? And Bruno already just talked about an important aspect to non-adherence, right? Which were the side effects as well. So does anyone have any ideas to like why the intention to treat number might be different from the per protocol here in this population?
Again, going with what we talked about in regards to the definitions of intention to treat per protocol, going with what the results showed in this study, like, can you say like why there was a big difference with intention to treat versus the per protocol analysis between both doses?
So then just reviewing a little bit the results from what we have seen on the per protocol analysis, there was a superiority of the 400 dose, but in the intention to treat analysis, there was no superiority of the 400 dose. And then for overall survival, progression-free survival, and overall response rate, overall survival, progression-free survival, similar between the groups. Overall response rate higher with the 400 dose. And then adverse events also higher with the 400 dose. So which dose would you use? Which dose should be used in those relapsed refractory multiple myeloma patients?
So Sarah is saying in the chat that she would probably stick with the 100 milligrams. Can you tell us why? There is, again, this is just discussion, no right or wrong, but what's your reason for that? Yeah.
So it seems like if overall survival is similar, and it seems like there's more adverse effects with the higher dose. which is probably what caused your difference between the per protocol and intention to treat. So it's probably better to stick with the 100 milligrams rather than the 400 because you're likely to have increased adherence.
That was a beautiful response, Sarah. That's exactly the point, and that was exactly the dose that started to be used in future protocols and future trials. I mean, future after 2012. So then, okay, we got a higher overall survival in the per protocol analysis with a higher dose, but then in the intention to treat analysis, there was no benefit in overall survival. Also progression-free survival, no benefit with the higher dose. Okay, overall response rate, I got a higher response with the 400, but to get this higher response, I also had to make the patient go through a lot of side effects, more constipation, more peripheral neuropathy, more somnolence. So is that worth it to make the patient that is already going through a lot go through those side effects just to get a higher overall response that may in the end overall not translate into a benefit in overall survival? So that's exactly the conclusion of the trial.
And one more thing that I would add, it wasn't only the adverse effects that led to the difference of the per protocol and intention to treat. Another benefit of doing kind of like the intention to treat is not just that you have like patient adherence a little bit more similar to what you can see in the real life, but also the physician intervention might also be a little bit more similar to what you will see in real life as well. If you check in the article, one of the main reasons why the patients deviated from the original protocol was steroid intervention. Or steroid addition. So once the oncologist saw that maybe like the patients weren't responding as well, or like that there was something that needed to be done, just checking the labs and clinically, like the evaluation of the patient, then they started adding steroids like earlier and deviated from the protocol in that way, which makes sense. That's what an oncologist is going to do in real life, right? If your patient is starting to worsen, then you're gonna maybe deviate from the protocol, right? You're gonna do other things. So in that way, the intention to treat analysis also gave us a little bit more of a realistic intervention from the physicians as well. And that was actually one of the major points as to why those two groups differed as well.
Exactly. Thanks a lot, Rafa. That's exactly what happened. And then so that was the conclusion of the study. Thalidomide 100 has an improved safety compared with thalidomide 400 with significant activity in advanced multiple myeloma. So take home messages. So ITT answers the question, what is the effect of assigning a drug to a group of patients? But per protocol in as treated answers the question, what is the effect of receiving a drug in a group of patients? Both of them have advantages and drawbacks as we discussed, but in most clinical trials, ITT is preferred because it will reduce selection bias, will reduce confounding factors. And then even so, per protocol in as treated can be used in specific situations, as we were discussing situations where it is important to know the best possible outcome and also to analyze adverse events, because I would only get the adverse events if I get the treatment in the first place. So just to conclude, okay, that's what myeloma researchers are doing into these days. So like I told you guys in the beginning, myeloma research is on fire, especially with CAR T cells, bispecific antibodies, and antibody drug conjugates being developed, and a lot of ongoing trials on all of those things right now. And let's see what the future holds. And thank you so much. Thank you guys for participating a lot. It was a bit tough for me. It's the first time I present an article or something related to statistics, and you guys did great. You guys participated a lot. So thank you so much.
So I think also you have been our first, right, intern who is presenting. So just give him a clap for for he is the first intern to present this academic year for EBM. So I think he did a wonderful, great job and very engaging. And I love the video as well. I was laughing. So I seen it as well. I seen the pods, the modules that they have. I added an article which I thought was very nicely done. It's from a nephrology journal, but it's actually a very nice article on just kind of elaborating a little bit on a lot of what we talked about between intention to treat and per protocol. What I like about it is it also even gives like some different studies and examples of why intention to treat or per protocol worked for this type of study, and it gives you even like the graphs and things. So I thought it was a very nice summary of what we talked about and already what Bruno kind of elaborated on. So again, any feedback is greatly appreciated. I myself have enjoyed kind of the flip with the EBM in terms of not focusing so much on the article itself, but more on making sure that you are able to have like a specific teaching point on what we feel like at the end of your first year, you should be able to at least know the difference between intention to treat and per protocol and which one, why each one is useful in their own way. And just to kind of date myself, that timeline that you gave with the medications, just know that as a second year, I gave a grand rounds on multiple myeloma to the hematology oncology group at Baylor, and that was back in 2005. So when I looked at the timeline, there wasn't much for multiple myeloma at that moment. So just I looked at that, and I was like, oh, and I thought I did an awesome job, but I realized that there wasn't much on multiple myeloma in treatment at that moment in 2005 compared to what's been happening in the last 5 years. So yes, so great job, Bruno. And any feedback again from the first years is greatly appreciated.